Morning. I'd like to thank the RCMAR organizers for the opportunity to share this work with you today. My name is Rhiannon. I was a pilot grant awardee at the University of Alabama at Birmingham in 2020, and I'm excited to share the findings from our project entitled The Role of Caregiving in Healthcare Utilization Among Obese Living Kidney Donors. In 2015, over 40 million individuals in the United States were estimated to serve as unpaid caregivers for adult or child family members. And family caregiving has been estimated to cost over $300 billion annually in unpaid labor costs and an average of $7,000 of out-of-pocket expenses per family. Caregivers are known to experience psychological distress and adverse health outcomes, including hypertension and heart disease, and in some cases, increased risk of mortality. There are also known moderators of caregiver burden. Ethnic minority caregivers have reported more depression, lower use of support services for their caregiving role, and worse physical health than their white counterparts. Older caregiver age has been negatively associated with physical functioning, pain, vitality, and general self-rated health. Rural caregivers have also reported greater financial burden than their urban counterparts. And these factors are particularly relevant to large medical centers like UAB that serve largely minority and rural populations across the state. Another moderator of the caregiving burden is obesity. There's a higher prevalence of obesity among caregivers and increased risk of negative health outcomes associated with obesity among caregivers. Obesity is also associated with greater healthcare utilization in the general population. We hypothesized that this adverse relationship between caregiving and obesity may be magnified when the caregiver becomes a patient themselves. In our case, it's a living kidney donor who was obese at the time that they donated and also served as the primary caregiver for their transplant recipient. This applies to about 20% of all of our living kidney donors who acted as the recipient's primary caregiver. Mirroring the obesity epidemic in the general population, we've seen an increase in the prevalence of obesity among our living donors. And we know that donors with obesity are at increased risk of post-donation disease development, including hypertension, diabetes, end-stage kidney disease, and also mortality. However, to date, no one has described healthcare utilization among this population. So the objective of our study was to explore healthcare utilization among kidney donors with obesity at the time they donated by whether they served as the caregiver for their transplant recipient. To do this, we used a retrospective cohort study of 640 living kidney donors with obesity at donation who completed a survey since March 2020 within the parent R01. And this is an ongoing retrospective cohort study funded by the NIDDK under PI Dr. Jamie Locke. For our study, we examined self-reported ER use, hospitalization, and primary care physician visits post-donation. Among the 640 respondents, 141 indicated that they were the primary caregiver for their transplant recipient. And not surprisingly, these caregivers were slightly older than those who did not report that they were the caregiver. This is standard or mirrors that of caregivers in the general chronic disease literature. We found no differences by sex, race, or baseline BMI, but there was a greater proportion of caregivers who fell into class 2 and class 3 obesity. We also found caregivers had a slightly higher baseline systolic blood pressure, slightly lower baseline estimated glomerular filtration rate, and they also, unsurprisingly, a greater proportion of caregivers stated that they were the spouse or partner or the parent of their transplant recipient. We found no differences by rural geography or CDC social vulnerability index. We next looked at our utilization outcome variables. And while we found no difference in the proportion reporting ER use or hospitalization since donation, we did find a greater proportion of caregiver donors stated that they visited their PCP more than once per year. Because of the interest in age and understanding whether the relationship between caregiving and utilization is modified by age, we also looked at subgroups and split the cohort at 50 years of age at donation. Among younger donors, while there were no differences in ER use or hospitalization, again, we saw a trend towards greater PCP visits among our caregivers. And this was a similar pattern among our older donors but it did not reach statistical significance. Because the question was asked at any time point since donation, we also created discrete variables for ER use and hospitalization within 3 years of donation and found no significant differences when looking at the crude proportions or in logistic regression. So we created an adjusted logistic regression model to explore PCP use. And we did find that caregivers had a 1.6-fold increase in the odds of reporting that they visited their PCP more than once per year compared to non-caregivers. We also found that older age, greater baseline BMI, and greater SVI were associated with increased odds of PCP use. We also took this opportunity to administer an additional optional module of survey questions specific to caregivers. And among our 141 caregiver donors, 30% report that they are currently post-donation the caregiver for their transplant recipient. And while about 42% stated that their caregiving role required 8 or more hours per week pre-donation, this had decreased to 28.2%, spending 8 hours or more post-donation. We asked several questions related to caregiver burden, and over half of our donors stated that caregiving was neither a physical nor a financial strain for them before donation. However, almost 70% of these caregiver donors stated that their caregiver role was associated with some emotional strain. Almost 75% stated that their caregiving experience had influenced their decision to donate a kidney. And unfortunately, half of our donors reported that the transplant center had not provided any support specific to their caregiving role. Caregivers were asked to elaborate a bit more on their response to this question. And among those who stated that the transplant center had provided support to them as the caregiver, the most frequent responses included the frequency of contact or availability of the transplant center staff, additional educational resources and information provided to them, the availability of one-on-one counseling or support for the caregiver, and financial accommodations or lodging. Among those who stated that they had no support specific to their caregiver role, many said that support was not needed, or they didn't feel it was the transplant center's role to provide support to them. However, quite a few stated that it was as if they weren't there. They were ancillary to the process, which is ironic given that the surgery would not have occurred without these donors' gifts. And finally, we asked how they might have felt more supported as a caregiver in the donor process. And frequent responses were the desire for more information on medication control, additional psychological support, someone to just check in and see how they were doing post-donation, additional financial resources, and the desire for better communication with the transplant center. To summarize our findings, we found no association between serving as a caregiver donor and ER use or hospitalization, but we did see greater PCP use among our caregiver donors. We also found a heterogeneity of support for caregiver donors that was provided by transplant centers across the United States. There are some notable limitations and strengths of our study, namely that COVID greatly impacted our team's ability to both enroll participants and enter their data. And we attempted to pivot to include a larger data source from our national registry data, but unfortunately we found that relationship type in that database was a poor surrogate for caregiver status. There was also the potential for recall bias from our retrospective survey design, but we do believe this is the largest cohort of caregiver donors that has been described to date, and that it does contribute some novel information to our community. In the interim, I've received additional institutional funding to study caregivers of patients with end-stage kidney disease, and findings from that award and this RCMAR grant will serve as preliminary data for an upcoming K01 application to study the needs of caregivers along the continuum of end-stage kidney disease. And I also plan to explore the association between caregiving and post-donation comorbid disease development to better understand why caregivers might have greater PCP use after donating. Again, I'd like to thank the organizers for the opportunity to share our work and also to be supported by RCMAR funding. I'd also like to thank my primary mentor, Dr. Jamie Locke, and I will be happy to be contacted with any questions. Thank you.